Пані та панове, пропонуємо вам
Ladies and gentlemen, please get back to us, to your audience. I hope that this discussion will be similar to the previous one, namely with the involvement in activity. And thank you very much for really being active and expressing your ideas. Please keep up the same tendency. The scheme of this panel discussion will be the same, with one difference that we'll get just one speaker with one presentation, and then we will get the general panel discussion. Let me invite with the presentation the doctor who has been several times addressed. This is otolaryngologist of MS PhD, Yuri Grebenyuk. Please choose your mic, and we are ready to start. Let me make a compliment to the organizers, namely to Ksenia Borisovna. So today we have a general, let's say, so-called general acknowledgement day of, MTB acknowledgement day, let's say. Let me introduce my slides and to transfer you all the greetings from my team. I say the team MOS Ukraine that I'm representing here. The Migrant Offshore Station, MOS, has been established by Christopher Cantrambone, American businessman. It unites, namely, 27 evacuation teams for the heavy patients, like, color label yellow and red. So we've got over 56,000 of evacuation cases. We are providing our activity within the framework of the memorandums signed by MOH of Ukraine and MOH of US. Let's switch directly to Akubarotravma. This is the acoustic trauma by sound wave and barotrauma, so that atmospheric pressure trauma. So we talked here about the semiotics, but these two really differ since, from the head trauma in sensorineural, for example, with so, and again, if in case the eardrum is damaged, the patient goes by the one course of treatment, and if not, if it's a different condition, so the different treatment is applied. So as you see, the Akubarotravma in anti-terroristic operation of Ukraine made from 6 to 7 let's say losses of service, and now the quantity is much more increased. Classification is rather conventional one. The center don't have any let's say specific classification. So we usually differentiate in the let's say mild, medium, and heavy hearing loss. So it can recover by itself, but then it's mild, medium when it is recovered in 2 to 3 hours, and the heavy when it's never recovered. And we also differentiate by sensorineural hair loss and the two other stages. The damage variants, it's first of all whether or not the eardrum is injured or not. Perforation, no, yes or no. So, and I always mention where it is right or left. And it's easy in the diagnostics and the further the treatment. So let me demonstrate to you the scheme. So just some words about the trauma itself. So first of all, the blast waves disseminated through the soft tissues and the bone tissues. The pathogenesis through the hearing channels, nasal channels. So this wave goes through the nasal and hearing channels, and so this way it's in the brain then, and so we get the perforation of the eardrum. Plus, we can get musculoskeletal tympani spasm. Then the hearing bones are affected and compressing. The sound, the villi also are infected. Plus, the nervous vestibulocochlearis can also be injured. The clinic that we face, clinical manifestation, it's same like blast trauma. This is hearing loss sensation, hearing decrease, vomiting, nausea, lack of or loss of orientation, or autotopics, vestibular dysfunction is present in Akubarotravma in 70% of the cases. The symptoms, as you see there, the general symptoms with occipital atlant instability, since we notice that this is a drone war, and the drones usually attack the moving objects in the plus we have not only Akubarotravma but so-called injuries similar to road accidents. So plus we have the diplopia, vision loss, dizziness, and loss of balance, and also the increased intracerebral pressure. It's so-called Cushing triad, bradycardia, impairment of breathing, and so on. So the red flags I will not say, so you see it here. So the acute reaction to stress. My first teacher was a neuropathologist, and so he always mentioned like acute reaction to stress. I started to get interested in what is really the stress reaction, and it can happen within 2 days or within a month after the acute trauma, as the soldier told me. So all was well. So for the 2 days, but after I started to respond the phone calls, I started to manifest the so-called 3D symptom: depersonalization, dissociation, derealization. So what I faced with, so first of all, the sort of guilt of the victim and the guilt of the wounded, and it happened with those who really are experienced war fighters. For example, I asked one soldier, why you didn't address the doctor? Say he was always going with the tinnitus and noise in the ears, and never addressed the doctor. Plus, he lost his brother in arms, and when I asked him why you don't address the doctor, he says, I don't want to be judged as panicking when it's a manifestation of the victim syndrome, or victim guilt syndrome. Next, what we are faced with is a pathology of the hearing tube and sensorineural hearing reduction, and also gastroesophageal reflux disease and hyponasal syndrome. Also, the next slide, I present you here my version of the questionnaire. What I ask my patients: first of all, I establish the eye contact with my patient. In case I don't have any response, I use gestures. Maybe he doesn't hear me, so I try to explain him with my gestures. Then I try to identify the circumstances of the trauma. And I ask the person, what is really, where is your pain? What's the most pain with you? So I establish the contact this way, and then I can switch to what is of real interest to me, where he has or doesn't have any concussions previously, in order to establish the right diagnosis. So what we do in a stop point, first of all, the mostly trivial things. For example, I have such a device. This is my camera tone. My wife is a pianist, so I took this from her. So this is it's like a tonometer or tuning fork, I mean. And this usually is really working when I put it on his head, so I can identify whether or not the person has a barotrauma, or not to get into the situation when the patient doesn't hear nothing, but the doctor doesn't see nothing in this. So how to how I formulate the diagnosis. I don't put MTBI. I put just blast injury, since the consequences of the blast injury can differ. For example, I've got a friend, chaplain. So he just tried to shot from the Stugna munition. I don't know why, because he's a chaplain, and he's got Akubarotravma. So that's why I put always a blast trauma, or then first I put that mainly the diagnosis of closed TBI, Akubaro blast trauma, and then I check whether it's with perforation or without perforation. Again, I don't put cephalic syndrome. I put cephalgia, as I was taught by smart people not to put the word, to avoid the word syndrome. And in case they came like 2 days after the blast trauma, I put blast trauma. It's let's say later days. So I put some specific, like loss of hearing was with a specific range, tinnitus, and in case I send it to my friend doctor, I put everything in detail. So what I say to my patient, please keep away from what I mean, to keep your ears as most far from water, not to get the water, not to get inflammation. We use turundas on sucking devices, then hematintinum. So when it says blood bleeding after the eardrum, but it can mask liquoria. I mean, this CSF leakage. So then we can identify the perforation. Then, but if in case it's a dry perforation, say it can heal by itself in 6 to 8 weeks. But we check for inner objects. But in case the eardrum edges have been, let's say, curved, so we have to treat it since, or I mean to
крючочками розправляти.
to make it even, otherwise it will not heal. Yeah. But no one does it, never. So far I see, not on the primary level, not on secondary level.
So they basically forget about it. So this is really bad. And also, the tampons that Oleg is doing, actually, yeah, tampon plastic. So I'll tell about it later. So infected perforation. So we use a special protocol for it, for the otitis. Okay, treatment, everything we actually discussed. So the stabilization point, I took everything that we inject. Okay. Okay. Beta-gestine, is there only if there's like the vertigo. Okay, in internet you can see this scheme like Vaseline anti-neuritis therapy, dexamethasone with a specific scheme. You can see it. I'm against this. Okay, so we don't use that. Okay, we don't use this for treatment. We inject dexamethasone upon the condition that there's normal pressure. It's not too high. I mean the patient. Yeah, the patient's pressure. When it comes to dexamethasone with tampons, so I can't have the otoscopy. I cannot put it. How can I inject this, dexamethasone? They're overreacting. I usually say they're very agitated, and I say, okay, you lie down. So in a day passes, I'll take it away because now you'll be inadequate. I will not take it away. Hyperbaric oxygenation. So I used to work in the ENG hospital. We had these chambers. I don't know why we need it here. Maybe you need some. Okay, this is the scheme that we have in Mechnikova Hospital. This is our leading one. Okay, so de-stressing IV, prednisolone, furosemide, diuretic. So the contraindications are there in instruction. So with other, combined with other, there may be ototoxic effect. Okay. Many contraindications are there. If you have hypertension, osmotic diuretic. But again, I can think that this should only be like if it's prescribed, okay? We can have it. And our standard scheme, I don't know how old it is actually, dexamethasone, Trental, Naloxone, Armidine, Nervitin, Nerimidine. Okay, nothing already to transfer there to ensure that, okay, nothing to transfer base. Okay, another scheme. I've been in railway medicine at some time, so this is their scheme, but this is one positive thing I'd like to draw your attention to because basically we heard of evidence-based medicine here, and we have to prove it with some evidence, based on some evidence. If no evidence, how can you basically base it on something? Yeah, you can just refer to anyone. So I worked together with a neuropathologist, a Doppler. Yeah, and with her, we were like, if we found the response, then yes. If not, we were searching. Many have spasms. And if you use Cetacline there or Trental, their head, like they have horrible, they like have this white noise in head, and pain. So lysine, not to burn the vessel, so I just dissolve it, 200 milliliters with physical solution, and it doesn't burn it. So it doesn't. And it tells 50 milliliters, okay? So you need just to understand what exactly. But there's a nuance why it takes place, because this is not treated, people. This is not treated. We were taught in a different way. If it's acute, they told me, if it's the first day that you come, 70% there is that something helps. If it's the second or third day, 50%. After that, that's it. Then it's chronical. Then it's chronic. So, but we have to treat it anyway. I had one patient, so every 6 months she was coming. So it was like a psychotherapy. She says, I need IV. I'll tell you why. Because she says, to stabilize. To stabilize the hearing. Yes, stabilize. And not to make it worse. Not to make it worse. What if he's deaf, like completely deaf? Then it's an open question. Tinnitus. Okay. This is the problem that we have, and we need to handle it. And because according to Americans and their data, we had Katie here It's their study. 75.7% they have the tinnitus, U.S. veterans, and 85% of these due to blast trauma. These are like they have this constant like white noise in their heads. Within the first days, they can't even like get rid of it. So it gets stronger when they try to fall asleep. They simply can't fall asleep. What they do, they say, I turn on music, like some noise, you know? So he has to sleep with noise, with some music. And that, in loud environment. I remember my grandma, she could only sleep when the TV was on. Everything, like, there was no programs, there's just some white noise and she's sleeping.
Це працювало. От,
It worked for her. Sorry for being too emotional. Okay. The intensity of noise. Okay, so we can say that definitely noise doesn't help us to act properly, kind of in function.
що це небезпека для їх життя.
This is the danger for life, they think, because they hear drones, you know, like they hear drones all the time, like drone noise. Nothing's over there, but they still hear the noise, you know, and people are really agitated because of this. They're anxious, you know. The consequences of tinnitus. Of course, people become very anxious and annoyed and depressed. And if you tell something to a person, you can't just even communicate. I had a patient. He had concussion. He had tinnitus, and in 3 months he stabilized. He says, "Oh, I'm so happy," and then again. And he says, "I have this like noise in my ears again." He had the question, "What will I do?" Diagnostics. Again, the questionnaire. So we had the lab. We have the lab, an institute, and we use the camera tone tests. You know, the Gilet test, tonal audiogram with glycerol test. It's about the labyrinth. The Meniere's disease, as we call it. The glycerol test, and it actually made the hearing better. We have new methods now. Impedance metrics and hearing reflexes, and also studied in sonography. Well, we can actually even record the joint functioning. Yeah. So treatment. The sensorineural deafness is treated, so it's associated. If you have tinnitus, well, basically tinnitus may be of other nature, and this can be also, it may be related and caused by many different things. But blast trauma can actually provoke that. So the same thing. Okay, for example, this blast wave can actually provoke something or aggravate something. The vestibular even functions can be aggravated. For the evidence-based medicine, we have a little bit different reality. You like live in tomorrow already. So don't forget that truly there are some achievements, you know, in results. So the Mathias sound stimulation method, the last one. This method that is widely used, by the way, for kids with autism and take these delivery traumas. This is also like when the child is being pulled, you know, during birth. We have this method. You just need to take this, Ksenia, and take this and implement this. And it will be fully functional. And you'll make a program, special program for veterans tinnitus. And this will stabilize them as well, yeah. This is a great stuff, yeah. So this is something that I practice, you know. I had colleagues telling me all that, and even so when she tried to work with deaf kids with implants and she taught them how to speak, okay, let's use the method. It's great that we have it.
написав такі слабо потенційні ризики наступу.
Potential risks of
Він його практично молодий.
grave
Раніше
ACBT.
по наявності акубаротравми,
If there were previous ocular traumas and ear pathologies, hyponasal syndrome, so the pipe doesn't function. Okay, I heard that. I take a combat medic. Okay, you have a lot of ocular traumas, so you will tell me how do you need to, what do you need to do?
а ну-ка давайте продуватися. Вони мене вчаться, ну що
And
робити?
they learn, like people who actually are in scuba diving, you know,
Я вже зазначу їх вже в обличчя, по фаміліям.
to clear the tubes, and I even know their names, like, I can see their faces all the time.
Ну, що момент травми. Тоді ми
Okay, the
лікувалися
trauma.
50.
So
Все залежить
it
від того,
depends on
що прилетіло, куди прилетіло,
what
які
hits,
були
where
в
it
нього
hits,
напрямки
if the
вчинення.
guy had the headset or not, you know.
Після травми. Ну, це більше якраз
After the
рекомендується.
trauma, it's more for rehab. It goes more for rehab.
Ми
Because
повинні
we have
їх
not only to
організувати.
detect the complications,
Ну, і надати їм
but also
допомогу,
to provide services, provide help for the person to get that help. So it's really unpleasant, but when the serviceman returns and says nothing helped, but the attitude.
дали стару схему, один раз прийшов
They gave the
лікар,
old scheme.
поступлення дали цю схему,
First time the scheme
другий
was before,
прийшов лікар після.
then the doctor came
Нічого
after
не
the
допомогло, опять
discharge.
зробили
Nothing
операційний,
helps. The
все
tinnitus is
працювало,
still there.
все.
Hearing did
До
not
побачення.
restore. Goodbye.
От. Ну, оце відео з клініки
So this is the video
професора Борисенко.
from Borisenko
Його
Clinic.
учень оперував
His student was actually
важку
operating.
травму,
A
яка
serviceman
була
got a
стовпна,
very
пройшов через ушну раковину, пробито скроневої кістки,
so actually a part of cartridge stuck
Я його
in
виводив
brain. You
при
know.
місці. Тобто я його побачив, я знаю, що реально
I
поможе.
saw him and I
Олег
definitely
Миколаївич, я до
knew
нього
that Oleg would help,
прямо
so I sent
просто.
people to him. Okay.
От. Його оперують в тандемі.
In
Тоді
tandem,
отонейрохірург,
we have the autoneurosurgeon
нейрохірург,
and neurosurgeon additionally
видаляють
there.
субтенторіальним доступом стороннє тіло,
So I extract
роблять
this element
пластику
out,
кривої
this
пірамідової
object,
ножиці, і все, людина що?
and we do it. We have the result, and
Співає.
the person can sing, basically. Yeah.
Так, це щось я не тут включив. Ну так, ну я вже буду закінчувати.
So I will finish.
Колеги більш детально розкажуть. Я тільки
My
про
colleagues will give
військову.
some more details. I'm just speaking about the military.
Що мені військові розповідають?
What military are
Тому
telling
що
me.
багато людей, які вже не хочуть
Because
самопротезувати.
there are many people who don't want to have this like prosthetics, but they don't know that they're intra-channel, you know, that we can pick the equipment, you know, the implant.
Вони знають реально,
And
що
those who
коли
know
внутріканальний
that if person knows, he knows that if there's
там
intra-channel, so they can actually even
і коли він
have the suppression of noise. So when they additionally take the tactical ones, he won't hear his own. There won't be noise, and this will be the prevention of a repetitive blast trauma. They have these tactical headsets. Those already had the problem, but they already had interaction with experts, you know, who told that. Tactical protection means this is not about advertising. No, don't recommend this. These are sold helmets, but my commander sent and said, okay, take this and this and this. So, not to give some wasting information. So, this one, you can hear nothing. It maybe will save you from the blast wave, but you won't hear the drone. And there are definitely some great headsets active, thin ones. You know, you can actually put it under any helmet, but that's really a good thing. $2,000. But this was really cool. Okay, we can talk a lot, but we actually need this sensor, by the way, and we need to have it.
яка вообще решить всі ваші
This will
питання.
be a universal solution for all the
Ніякого
problems in discussion.
скажімо так, ключі немає. От, сенсор все
So
реєструє,
this sensor
потім після
registers
того, як
everything, and then after
достаєте
the battle,
комп'ютер, він
put it in
не
the
тільки
computer
вам
upload,
там 5, 10, скільки в нього викликів, все,
5, 10, or
ти,
how many
ти
blasts,
потребуєш
whatever. So
в енроді, ти потребуєш лікування, а
So
ти
if you need
потребуєш
treatment,
фізіотерапії.
if you
Все це
need
буде
forest
записано.
glade, everything will be there, okay? It will give you a clear prescription.
Висновки, в принципі, ви
Okay, conclusions.
зрозумілі. В
It's
разі
pretty clear.
оскільки слух не відновився, ще
If
це
in 72 hours hearing is not restored, consultation. Not always you have the otolaryngologist there, so I would send them even before 72 hours.
Я про доказову медицину
About evidence-based medicine, yes, something should be there as a backup.
криворогіометрії.
Audiometrics, transcranial Dopplerography,
До речі, класний метод,
and
який
sonography. Okay, this is a good method.
зафіксує легку закриту, тому що МРТ не діагностує.
Because MRI does not diagnose this, and this will,
Користуйтесь.
but you don't use it.
Ну так. Ну треба ж всього описати і все. І ти будеш знати, ти це певні структури пошкоджені.
So you will know which structures are damaged, okay?
В нього кора, туди. В нього гамма чи дельта. Ми дамо потрібний
So
препарат.
gamma or delta, you'll give some proper treatment. This will be like backed up. This will be based, but not just standardized, okay? I'm being emotional again.
Що є ще? Противітус. Ну, тинітус я вже розказав.
Tinnitus, I already told you about this.
І про індивідуальний захист. і
And individual
засоби
protection means
моніторинга теж розказав.
monitoring, I told you as well.
Акубар, це нам дитинка
Yeah, we had a kid, yeah?
і повісили на дворах.
A kid made that drawing, and we put it, yeah, and she says, the kid said, this is Akubara, like, yeah, this is the condition with a trauma, yeah.
Не посилай мене, тому що вам
I even tell my wife, please don't send me there because, you see what happens, we all are growing and extending.
поки війна. Все, дякую за увагу.
Thank you for attention. This is very good that you were emotional, and we've seen that a lot of feedback there was emotional feedback. Okay, so second part will be as discussion, and for you not to be lonely, as the only otolaryngologist on the stage, I'd like to have your colleagues with us. We have also otolaryngologist from Military Clinical Hospital, Olga Sherbel-Trochimenko, please, your colleague. Also the head of the ear microsurgery unit, Kolomichenko Institute, Dr. of Medicine Oleg Borisenko. Okay, so ladies and gentlemen, dear doctors, those people who already told that they had certain questions, they will ask you these questions. So I want to have two moderators. Instructor in technical medicine, Maria Nazarova, support her please, and therapist, Aher Artsemovich. Okay. Okay, let's try to have it all in 25 minutes because we are out of timing a little bit. That would be good. Thank you so much, Yuri, for your introduction. I think we got now very good understanding what is Akubarotravma for the stabilization station, where actually the first words should emerge of ACBT. And I'd like to ask Ms. Olha now, okay? Okay, the military hospital, okay, the main military hospital. Who actually goes to you? With which patients you work the most frequently? And maybe what trend you can observe for ACBT, okay?
The tendency is that form number 100, we get the patients already examined in the disease history. Where is hospital? The final stage, we got the patients with ECBT. We prescribe corticosteroids and all the range of medicaments in order to improve vessel traffics. Started with osteocinat, cytocolin. I would say that we can get from 5 to 50, let's say, prescriptions, medicaments or types of medicaments, including corticosteroids. So we see patients with already positive changes or without changes. So sure that we are a highly specialized clinic. We usually discard the majority of medicaments that were prescribed. We keep up corticosteroids and sedatives, and we see that the patient receives nothing, and it's not good. Yes, psychologically is the way, like in case you give more attention to the service member and you refer him to psychiatrists, psychologists, or neurologists. So with a sub point, I received even much more treatment than in your center. So how can you, let's say, comment? Well, I see that we start the fight scene on how much medicaments you prescribe. Uh, Almost all the patients have ACBT, and you get rather severe cases. Maybe you see some unnecessary prescriptions, like surgical intervention. From the surgical point of view, as Yuri said, lots of doctors in primary care line, they see usually serum and some dirt, and they see just this and they don't wash it out. Maybe they don't have time, they don't have means, they just put perforation and that's all. Or secretorytitis or prolentititis. So since in case one has a perforation, you have to prevent let's say, any liquid to get into, and usually the patient come with compromised ears. We cannot do the ear plastics since it should be some other type of intervention considering the bacterial infection. Whether or not my understanding is right that the majority of patients who got to the central hospital just because the people on the step points cannot use the otoscopes. I think that they don't need to use the otoscope. Rather, they have to question the patient to collect the anamnesis, sure the noise and tinnitus they will have, but whether or not you need the otoscope on the stop point, I don't think that it is needed. I think it is needed. Yuri, let me answer. You know, when I was about leaving for the Congress, I was asked, so please train us into using the otoscope, and I insist on the stop point to have the otoscope. Yes, sometimes you don't know how to see, how to observe. But nevertheless, you can see the blood, and then you can specify the preparation with the question. So whether or not we can see all the perforations with the otoscope, so requiring the surgical intervention on the later stages. Yes, after ECBT, most of the perforations are healed by themselves in case nothing prevents them from. By the statistics, it's about 80% of perforations they heal within 2 months. Sometimes there are situations when the perforation is not healed. It happens when the wound is contaminated or when the epidermis comes into the wound of the eardrum, or a flap of the epidermis getting in the eardrum, so it prevents from healing. Sometimes they have the nasal breathing problems when the hearing tube is also injured, plus infection. When the perforation is accompanied by arthritis. So after the doctor sees a perforation, or the soldier comes with the perforation, with the blood, with the dirt, what you have to do is first you have to examine, to wash it in a due way in order to prevent the surgical intervention. In case the perforation stays, so we do tympanoplastics, we restore the perforation and then we cover it. Sometimes we have to recover the hearing bones loss, since the ACBT leads to the fracture of the hearing bones, and it needs the prosthetics or recovery with the cement. Concerning the conservative treatment, like of neurosensory hearing reduction due to ACBT, we have the evidence-based fact that with the ACBT, the inner villi are injured. These are not restored, and unfortunately, we cannot recover the hearing with such a trauma. We got cases with a full hearing loss, and we made a cochlear implantation. We got a patient, he was a sniper. We did him a bilateral cochlear implants, and he with 2 implants, he get back to the front line, and he says he's much better now hearing the drones approaching, since the cochlear implant can transfer the frequency that human ear cannot fix. So yes, so it's a cyborg, yes. Talking about the diagnostic methods, so we know that the audiometry also is getting closer to the primary line. Yes, we have such idea to make by ourselves the audiometry, namely to the patients with the hearing loss. So we know that it's not cannot be treated, but nevertheless, we use it to identify the range of the problem. Yes, we got the acute neuropathic intrasensorial hearing loss. Say it's not linked to the blast trauma. We've got such patients, and those of them who were treated in our clinic, we see that yes, it's a treatment has sense. When you start, it's in within 3 days. You mean the steroids? Yes, steroids and nootropic preparations in big dosages. This was like a shock therapy. It's a high doses nootropic, IV solution, 12 grams plus corticosteroids, 2 days, yes, in a row. I love hormones. Do you use them? Dexamethasone from 48 milligrams, the starting dose, and with dose with the dose titrating by 4 grams every day. You talk about namely of this idiopathic patients whom you treated with corticosteroids and nootropics. Yes, and we already published the work that we did. And do you have any idea to try in our patients? We try, yes, we do tries, but unfortunately, we don't have any effect. We don't see any effect. We are afraid to prescribe the high dosages of nootrops to the concussive patients. We do just 4 grams IV by IV, so then the dexamethasone also not more than 24 milligrams with titration. Let me ask colleague, in case the nootrops don't function with the warfighters, but we continue on corticosteroids up to 1 week. In acute cases, up to 1 week, dexamethasone and prednisolone, they can act really, they can work. Nootropic preparation, no. Yes, that's true. We administer the corticosteroids to everyone after ACBT. First, it increases the resistance of the inner ear to the toxic factors. In case we have the eardrum perforation and infection, and it increases the reactivity, and also the increases susceptibility of nervous systems by nootropic treatment. And yes, as of today, we keep them within our guidelines for usage. Okay, let me respond. So it depends really on the stage. Since on our stop point, first, in case we use nootrops in high dosages, it will, let's say, over excite our patient. Maybe like a starts in particular in the starting moment, yes, they will increase the excitement, and also they will disturb the sleeping. When talking about instructions, please, we'd like to get on the screen the instructions about ECBT. Yes, and the military surgery chair of Kharkiv University. It's been used widely. These are methodological recommendations, and we know that it's not a standard, as per Ukrainian legislation, but MOH never gave any guidelines on how to treat CBT. And so we usually base our activity on this document. Are there any persons using this document in the audience? Oh, you see it for the first time? That is very interesting. You know, whatever is the specialization of the team head, nevertheless, they can take such documents for usage. So let me read it. So the acute period, the first line we see the, and second line of medical treatment, dexamethasone, we've seen vimpotzetin, cinnarizine betahistine, the sebazone, hidazepam, sedatives in ondansetron with vitamin C. So everything should be uh, given to the patient right after ECBT. And then the wounded person should be sent to the first line plus magnesium sulfate, cericisabazone in the night, pain relieving medications, and then on the second level, nitrogalin, ceticolin, and the substitute for the dexamethasone. Do you know which? Prednisolone? No. Analyzing is not. In case the dexamethasone cannot be used, we know that both of them, okay, they can be used. So now we understand why we see all these preparations in the form 100. And they all are prescribed altogether, yes, to everyone, altogether to everyone. This is through 7 to 8 days for treatment. And in case of the positive dynamic, then the vimpotzetin, cinnarizine are prescribed with cinnarizine from 7 to 14 days. I calculated in case the patient pays from out of his pocket. Usually it is the same. It is, I mean, it is the situation. So in 3 weeks, he will spend 410 hryvnia. It's not much. Using Pacitin beta-histine, yes, they're rather cheap. I see that you can afford it, yes. And we know that concussion and ACBT will happen to everyone who will get on the stop point. So it's already full. If we calculate altogether, it's 41 million. And so we can, with this money, we can buy the headsets which are purchased by the best detachment. Well, I know that many changes have been happened, and not only stop points, but only clinic, the hospitals and clinic centers are working with it. And I think that the recommendations 2024 will be different.
At least a little bit different with the evidence-based status of the number of medications prescribed. Again, about the procurement and money and funds. Well, for the medicines, okay, we have the prosthetics, okay, hearing prosthetics, okay. Many military people come and we cannot handle with medications, unfortunately with surgery as well, so they require prosthetics. Okay. For the procurement of prosthetics for this specific category, it's at the expense of the military, you know. MOH, like a month ago, for the first time, they procured the hearing devices, and lysine has been there for years. Okay, good and bad news. Bad news, recommendations, current ones, and the good one will be presented by Ksenia, and she has some relation to the good recommendations emerging for these to merge. Okay, maybe. Okay, we'd like the tech team to show the second document to see how other recommendations updated look like. There are many like protocols of NATO standard. MOH is adopting these as the key body that actually is entitled to do that. They have to do it. So these protocols, of course, will cover the MOD medical component. And a couple of months ago, we had the first block of protocols, approximately 8 or 10. The first batch was adopted. I was in the second working group because TBI and concussion was there as well. And yeah, the protocol for acute trauma and hearing auditory trauma. Okay, so next working group will have it on Monday, on 21st of October. We already read everything carefully. We had to for the concussion, by the way, for the concussion as well, I'll add a word. And I do hope that, yeah, there isn't everything that we have here, thank God. And I hope that we'll have this very good professional step. But I'll tell you like an interesting thing from our working group. When we were adopting this protocol on hearing loss and concussion, it was small, like translated and adopted. It was the only protocol where there were a lot of hyperlinks, you know? Like to treat headache, you need to use the headache protocol, and another 16 pages there. And vertigo, okay, you use the link, hyperlink, and again, another protocol. So sleep deprivation, other. So for one protocol, we had like 5 or 6 others deriving, and it actually delayed everything for us. But for the concussion, but I think this is like it's a victory at some point. And I think that eventually in October, in the beginning of November, we'll have another beautiful thing there. Yeah, with a great result. So look, this joint trauma system, and we'll have it in Ukrainian English. It's translated, checked by the working group from MOH, and we have one of chapters, screening, audiograms, so certain guidelines for it. Okay, we need to know what to ask volunteers for. Audiometrics, comment. We have many microphones. Okay, audiometric screening is quite a complex thing. Apart from the equipment itself and device, you need to have this special chamber. Okay, and if you want to organize that. Plus, you need to have an expert audiometrist who will handle that. So, this is a hard thing. And if, upon condition that we can get this expert, yeah, why do we need to actually run that if it's not treated? Okay, we have camera tones and diagnose an ACBT if you don't have otolaryngologists, you have musicians.
Я хочу 2 слова ще сказати
Uh,
з приводу цього протоколу.
Speaking of the protocols, just a couple of words. We need to see if this is etiological, pathogenetic protocol, symptomatic. Okay, what I know. ACBT is a part of blast trauma. This is basically one mechanism. Neuropathologists treat it that way. Ophthalmologists the other way. But I don't understand. When I worked with this doctor neuropathologist, I actually understood, like, she's such a smart person, you know? So she was backing it up with something, and we need one unified scheme to treat the blast trauma, all right? And we'll have nuances. If something was eyes, then it's for the eye concussion. If it's for hearing, then we give some medications that work. Evidence-based medicine. Only within that. Oleg? Yeah. On audiometrics, I'm pretty not sure that we have to do it. So yeah, we have to ensure the technical support, audiometric equipment, I mean. We need to have experts who will use that. In our institute, we have many rooms where we have qualified audiometrists. We have nice equipment there, and everybody have various audiograms. And I always recheck the audiograms. With my audiometrist, I trust. I've been working with him for 30 years, so it's not that simple, as you think. And I agree with Yuri that at primary level, maybe it's enough to have a camera tone or the scope, and this is like this will allow to detect the perforation of eardrum and if the nerve is okay. Next level, of course, we need to have the audiogram and to check the hearing level. If we take these recommendations and American that we used and translated, so logistic disaster we can't refer all to your institute in 72 hours after trauma. Not always we can even with an tactical group we can do it. So everybody understands that complaints for hearing complaints without any confirmation is pretty subjective, but we don't want to miss the moment. We understand that we need a good specialist, a professional, but is it worth trying to do it as fast as we can or delaying like for 2-3 weeks when maybe this will happen in other places? You have to remember that this is also subjective method of study, and a military, meaning patient, can actually affect the results of screening. It will be really hard to run those tests and to screen that and to evaluate it. Okay? So, yes, I say yes to this idea. If it's possible to have audiometrics as soon as possible, this is a good thing. But you just have to be like conscious. Just please, it's very complex. It's not just buying a device and putting it somewhere. You need to have an expert who will use that. Okay? Within all these 10 years of work, realized that we can do miraculous things, approach patients to something that we only had at secondary, tertiary levels. So maybe this will work as well. Not instantly, not tomorrow, but we have to be ready that we will have a new protocol, a sectoral standard based on Ukrainian legislation. Maybe we have questions from the room to our expert. Okay. Someone wanted to add, yes, I just wanted to clarify. So you use NATO standards, as far as I understand, protocols of their standard, 72 hours from the moment of ACBT with certain complaints, but in 72 hours, it means that there must be a curation of otolaryngologist. It's mandatory. As far as I know, it says nothing of mandatory screening of tone audiometrics. Only if certain complaints are there, yeah. And if it's necessary to send to doctor, but not always. It's even referral to civilian specialists. Everybody wants to go to otolaryngologist, but sometimes there's a line. If it's impossible to go to doctor within 72 hours after the trauma and with complaints, what's the sense of audiometrics? We lose it because there's no doctor like at this level. Without the doctor, what's the sense of tone audiometrics? It's a great screening study or test. It has to be done, it has to be there. But at some stage, as Alex says, even our audiometric nurse, she she had a special training in the institute, and our test is different from the test in other military medical centers, and the institute test as well. I understand this. It's not about professionals. Either we have it or not. The problem is it worth doing or not? And if we have something that's more serious than just minor hearing loss, do we need to mingle with therapy? Again, we speak of hormonal therapy, not the huge dosage like 48 milligrams of dexamethasone, but still. If you have otolaryngologist who can check the audiometrics and make certain conclusions and give the treatment, yes, it's worth. If you don't have this doctor, then it's not worth doing it. Thank you. As always, it's about the cost effect. Yes, so calculating the resources. Do we have enough of doctors, front forces? Do we have enough of money for audiometrics? Friends, any questions? Well, you will be sorry then that you don't ask them. Miss Oksana, please. Yeah, you've been the only one for quite a long time, just for you to know. In hospital, I managed to fight for audiometrics like in 2017 in the main military hospital. Yes, Minister Poltrak, we convinced him. Okay, so when we speak about audiometrics, we have to control it first for all hospitals to have it and all civilian hospitals, because we have this, like, all injuries go with this blast trauma. If we manage to equip all these hospitals, 90% of civilian hospitals take our injured people. And just like hospitals, not centers, the main hospital, military hospital, but just hospitals with 100 to 200 beds, if they have audiometrics plus otolaryngologists, then we will have the protocol. And we'll be able to send anyone in 72 minutes to these hospitals. If these are civilian or military, it's about One Health, by the way. Thank you. So, dear friends, in this case, we offer you to keep your ideas and insights for your resolution. And get ready for new sectoral standards on ACBT. And let's count money. It always is important. Thank you so much. I'm grateful to all the speakers. And I want to tell you, dear surgeons, yeah, you have a collection of cases. Not ears and humans, I mean, but some information and portfolios, descriptions. I think you can talk to them. Yeah, and ask them questions. So we are grateful for this panel. Okay, you have a chance to step up to walk. Okay, let's have a small rest, 20 minutes of coffee break, and even half an hour of it.